Discover KDH Collective's Leaning into Therapy podcast, an enlightening exploration of therapeutic approaches and evidence-based protocols. Join us as we delve into the vast landscape of therapeutic interventions, guided by the belief that collective intelligence surpasses individual expertise. Led by Katie Holmes, a licensed professional counselor with 16 years in private practice. This series offers valuable insights, expertise, and training from a team of skilled therapists. Prepare to immerse yourself in the world of therapy, created exclusively for therapists by therapists. Welcome. So, today is gonna be Keisha Holmes. I'm an LPC, and Bryn Angel. So Bryn is an LCSW, and we are going to talk about our upcoming class, which we're really excited about. So Bryn, do you want to say anything to our listeners? You want to introduce yourself quickly?
Sure. I'm Bryn Angel. I've been in the field for quite a while, but I love working with people who feel stuck. I love working with everyone who's a teenager through a young adult, and even my older adults now that I've been working with. Most oftentimes they tell me they just feel stuck. They've tried maybe therapy for a long time, or they just are ready to do that trauma work now. And I love giving you guys the skills and the treatment that you need to find your success so you get unstuck.
I love that. So one day me and Bryn were talking, and she said, it's not that the client is failing therapy, it's that therapy is failing our clients. And man, I love that. That has resonated with me since then. And so I think when it comes to like learning and teaching other therapists, we're really trying to give y'all what took us forever to learn earlier on. So
Exactly.
we have an upcoming advanced trauma-informed therapy course. It's a hybrid format, live and in person. You don't have to take the first one to take the second one. And so today we're going to delve a little bit into the advanced course and what it's about. So we're going to start with our first question, which is, how would you describe developmental trauma? So Bryn, I'm going to start with you. How would you describe that?
Well, to keep it simple, developmental trauma is a pattern of repeated adverse experiences in your childhood. These adverse experiences can include anything from just repetitive emotional or physical abuse. It can be things like chronic misattunement, inconsistently having those needs met. If you don't know what attunement means, that difficulty in working with like perinatal and postpartum parents, we talk about the bonding and the quality of the bonding. When you have that bonding and attachment difficulty, we can be looking at some developmental trauma as well. So it's just that repetition of those adverse experiences over time.
I call it the slow erosion of self. That happens from some sort of, it could be like physical, emotional abuse. It can also be like substance abuse, alcoholism in the family, severe mental health issues of a parent that's consistent and chronic over time. It can also be a single incident. This is rare, but it is possible that one incident that's really, really bad could impact someone during those developmental years. So, when we're young and we're developing and our brain's still developing, that's when these events would be occurring. So, when we're in the course, we're going to go deeper into this, but we wanted y'all to get a taste of it. I think this population that has developmental trauma, myself included, they end up having the most chronic mental health issues that can be the hardest to treat, where I feel stuck as a clinician. So I think that's why we're covering it in this course, is to get you guys to start understanding that more intentionally.
Absolutely, especially those clients who have generational trauma through that family lens, and we're trying to heal that, and they've just like, I love the word stuck because that's how you guys, that's how my clients come to me. They're like, I'm just stuck and I don't know what I've done. And a lot of times they don't know that it's developmental trauma because it's been this consistency. It's just been their life.
I love that. Yeah, they'll leave the little trauma part empty. on my intake, right? So it's not, they're not coming to you like, hey, I got developmental trauma, but it is what you're going to look for if you have a stuck client. So when we cover this, we go through a biology of the brain and things like that, but we also look at shock. So
Mhm.
what do you want to like, I guess, what are the effects of shock? Why is it important to understand when treating trauma? Why do we cover shock in this course? Because most people don't, I think, in courses like ours.
I think what most clinicians can say, maybe up until this point, is that shock is the piece we've missed, right? At least I can say that for myself and many of the clinicians that I have the privilege of working with. And it's so important because it's that original place where that trauma happens, where when we first orient to something and then we experience the shock of what we're noticing, what we're picking up, what we're hearing, what we're sensing into. And I think of shock like a pillow. And this is how I describe it to my clients. I think of shock like a pillow and it just holds you. It keeps you from having that big fall. It minimizes the intensity of the emotional intensity that's happening when you're experiencing the shock. It optimizes your ability to survive the moment, and it protects that emotional overload. It prevents you from having that extreme profound experience. So when we talked about that developmental trauma, there's a lot of things that would be just so overwhelming to the system to come into contact with. I'm experiencing this thing now, and shock provides you that nice little pillow to brace you, to hold you, and then allow you to experience the next parts of that sequence.
Well, and I mean, she's talking about the sequence, and it also locks your emotions in. So it protects you, but then it holds the emotions, but in a way that you experience the emotions, but you can't access the root cause of it or the beginning of the process, right? Of the sequence. This is something for another course, but just know it serves two purposes. And so if you've done or been a part of other trainings that talk about trauma informed therapy, like EMDR, it doesn't really cover shock. I'm EMDR certified. I've never learned about shock there. And it's a very important part of what's going on in the biology of the clients that we're seeing. And so we hope that our class gives you a little better understanding of it. Uh,
Yeah, and we'll talk to you about what it sounds like in our course, what it sounds like when your clients are in shock. What would their statements be? We will talk about those things too. It's really important to know if your client is in shock, what words are coming out of their mouth, how they might explain their experience, and how you talked about it's like holding all those emotions and how people don't feel like they're quite connecting to those things. Well, what words will your clients be using? So it's important for you to know what that looks and sounds like for sure.
Well, and next we're going to talk about, which is my favorite topic. So, why is it important to identify sensory differences and neurodiversity when you're looking at complex cases? We have a course that's called Mastering Complex Cases, but the advanced course, we start talking about this idea. And so, what do you want to say about it? Because I could go off on this topic.
Well, I'd love you to go off on it and then I'll just bring it in because I think this is your like baby, as I like to call it. It's so important to you. You've learned so much about it and it's really helped all of us to have so much more impact on our clients. So I'd love you to go into your spiel.
So, so neurodivergence is just like neurological differences, right? This is the brief, right? Across the whole human species. Neurodivergence, the most common things we talk about are ADHD and autism. But there's also sensory differences in this
Mhm.
population. I think when I first started learning about this, I thought that it wasn't trauma, that it was just sensory differences. The deeper I go into this, the more I learn that most of our clients have both neurological differences and trauma, because trauma can create similar sensory differences. And so being aware of this in your client is so impactful when it comes to stabilization and coping. These things inform how people cope in such an intentional way. I can't even, like, it is mind blowing to me. Like, even if they don't have autism or ADHD and they just have like a sound sensitivity, if we do some modifications for that, they'll actually have less mental health symptoms. It's crazy. Like it manages it so beautifully and efficiently.
Yeah. Yeah, I love what you said because our ability as clinicians to see the neurodiverse needs, to see the neurodiverse experience, allows your client to better understand their experience, maybe when no one else has explained it to them in this way, or that they even struggle to find the words to explain it to them. So it allows them to better understand their experience, provides them hope towards their wellness. Like, I finally know what I'm dealing with, and you have the strategies to help me through that. And then it creates a plan for them to start creating the life they want to live in a way that suits their needs, instead of trying to do it the neurotypical way or like Susie does it. So this neurodiverse piece that we're going to start giving to you through this advanced course is just a beautiful gift to the clients that we serve in helping them in that compassionate care.
I love that. I love
Yeah.
that. I think it's a very good description of like attuning to them a deeper level than maybe any other therapist has before. When you attune somatically to someone or to their nervous system, you are more efficiently attaching and noticing them than they've ever been seen before. So, yeah, we will go into that in this course. How does maladaptively stored information sound in the therapy room? But I actually want to ask first, what is maladaptively stored information?
Mhm. Maladaptively stored information is the attempt of a misattuned person, whether because we're misattuned to ourselves or someone else is not attuning to us, to make sense of and deal with the shock. It can look or sound like negative perspectives of self, substance use, thoughts of self harm, thoughts of death, disordered eating, ruminating, maladaptive daydreaming, that over control or hiding, that irrational beliefs. Yeah, I think a lot of us go like negative thinking, negative thoughts about self, shame, right? But really, that maladaptive stored information is that misattunement that happens and when we experience the shock and we're misattuned to, then our body starts to make sense of the world around us and ourselves. And that's where we get misguided and store that maladaptive information.
Well, and I look at that piece kind of in the lens of like, okay, so it's in the presenting problem. So when our clients come, it's going to be their presenting problem. And it's stored in this neural pathway. This is how EMDR talks about it.
Okay.
So in this like line, so say you early on felt like everything was your fault. It's my fault. It's stored in this neural pathway, and then every event similar to it is stored in that same pathway. So
Mm.
it's when we try to be like, no, it's not your fault. We're going to start this new neural pathway. Our clients have tons of data in their brain stored in this pathway that we're trying to counter that it's not that simple, right? This is biological. And so their maladaptive stored information is a part of what we're trying to address. But in trauma therapy, we're doing it in a more biological, intentional way than just like how we would through cognitive behavioral therapy, right? Which would just be a cognitive challenge. We're going to be more intentional about where we're going. And I think it's
Mm.
the important differentiator. It really makes for more effective care.
Absolutely. When you understand how the trauma is stored in the body, it definitely makes for more effective care, right? Yeah. And why that's protective for sure.
I love that. And then what are the main principles of stabilization? So stabilization is a very common term that we talk about in trauma informed therapy. It is like, I mean, it's like the centerpiece of it. Um,
Yeah.
so what's the main principles of it?
Stabilization may be one of my favorite things to do. And for me, it empowers the client. So, one, it educates them. It forces them to be accountable. Like, this is my load. Even though the rest of the world may have had me experience these experiences, My load is what I'm experiencing on the inside. So it forces them to be accountable to what they're experiencing, and it builds trust in that therapeutic relationship. So overall, your client is going to be so empowered by the stabilization where they felt out of control for so long. They now understand they can have more control over this emotional tidal wave, is usually what we call it in my office. And then it builds that trust in that therapeutic alliance so they can continue to do the healing work that you want to do with them.
When I almost look at it like the emotional dysregulation, right? If it's like a little like wave, that's what stabilization is. We're trying to make it less of a wave, less ups and downs, a little more stable, as we would say. And it's very intentionally informed by the biology of the brain when we're doing this type of work, especially in the way that we do it because of the
Right.
neurodiversity and the sensory differences that we use to inform our work. It really, I mean, it's just even more intentional.
Yeah.
So I love
And
that.
depending on what type of, and we'll walk you through too, depending on what type of client you're working with, whether I'm working with an over controlled or under controlled client, why stabilization is important. Because we can have those extreme feelings or feel nothing, and stabilization isn't a flat line or a woo, it's that. Yeah.
I know. I love that. I love that because people sometimes think stabilization is like this Pollyanna state of like
Yes.
happiness and what. No, no, it's just we're just trying to kind of lessen it a little bit. But
Yeah.
we'll go more into it. The class dives really deep on that one. And think of stabilization also, it's what we're already doing in therapy. So most of what therapy is about coping strategies. But when it's done in trauma-informed therapy, it's just done more intentionally based on the
Mhm.
nervous system. So you're not going to have to learn all kind of new stuff. Like it's just going to reinforce some of the tools you already have and inform which ones to use a little better. So what is the one takeaway or what's a takeaway that you hope participants get from our course?
Huh. I think because I'm so it's so important to me that people have compassionate care and that you're attuned to your client, that I want people to understand that there's function in the dysfunction. And when you can understand the function, you and provide those effective skills, you allow your client to be insightful, compassionate, and accountable.
I love that. Man, see, I my go-to with this is about intentionality. But I do like the reframe of compassionate care. A lot of people that are stuck have a lot of shame and stigma about being stuck. And I think it really resonates with me that we're giving them more compassion for themselves, which they might otherwise not, they wouldn't have gotten. And maybe they would be failing therapy, right? And
Yeah.
for me, when I answer this question, I like the intentional. I'm such a natural problem solver. Like I will die probably solving problems. Like it is just something I do. And so I
Yeah.
love being intentional. It took me so long to understand intentionality in the therapy room. So if I can help people get that sooner than what it took me, oh, I mean, I really floundered. Um,
Mhm.
until certain protocols just resonated and I met the right people that inspired me, you know? Uh,
Right. That's why we say you can't fail therapy, but therapy can fail you. And it's our responsibility to be like, this isn't working for me. Right. Yeah.
love that. I love
Yeah.
that. So what is something that you want the participants in the class to learn that you wish you had learned earlier in your career?
Man, I wish young me would have been so much more open to the biology parts of therapy because biology informs you. Um, and it's so important. I know it's complex, and I know that as humans, we can't know all the beautiful nuances that are our human anatomy, but we know a lot. And we know a lot that can inform your work as a therapist and help you help your clients effectively move through their healing process. So if you take, I guess I just really want you to learn how biology informs you.
At the same time, know that this is simple biology. I mean, it's way more complex than what we're going to go into. We're just like given the basics so it makes
Yes.
sense. Yeah. Because,
Yeah.
yeah, I think for me, I want people to know about neurodiversity. I have a personal thing in this, like I'm ADHD. People still don't talk about it when I'm in therapy, which is crazy to me because it informs so much about who I am. And so my hope is that I can empower more therapists to use the knowledge that we already have about mental health. And this is not new stuff, but we can include it in the treatment. There seems to be a disconnect between like the diagnosing piece and the treatment of mental health is all I can start to understand, I think, or what I'm starting to understand in this at this time in my life. And I want to fuse, like bridge that disconnect more intentionally. So I can help my clients quicker. They shouldn't have to suffer till they're 48 or 40 years old before they get some answers, right? The
Right.
information is already out there.
Yeah.
So
Absolutely.
we hope you guys check this out. Marielle Babb will be presenting with us. She is just not on the videos with us. We're really excited about the course. We've done it before. It's going to be, I think, round two, huh? Is this the second time we did it?
Yes.
So join us for
Yeah.
more.